I, Dr. Ankita Pandey, on behalf of the organizing committee, welcome you all to day 2 of INASL 2025. We are here for the morning workshop on artificial intelligence, and I'm delighted to call on stage our esteemed chairpersons for the session. I invite Dr. Akash Shukla from Sir H.N. Reliance Foundation Hospital, Mumbai. Welcome, sir. I invite Dr. Sonal Asthana sir from Aster Integrated Liver Clinic, Bangalore, and Dr. Ashok Chaudhary sir from ILBS, New Delhi. The stage is all yours, sir. You may please invite the speakers. Thank you. Mic check. Just switch it on.
Yeah, it's an absolute pleasure to be here, and it's nice to see so many of you here bright and early. Obviously, this is something that's of interest to all of us. Artificial intelligence seems to be shaping every corner of our reality these days, and more so in medicine. Every day there seems to be a new advancement, and often it's at a very dizzying pace. It's hard to keep up with as well. So clearly, like ourselves, are very interested in learning about how AI is going to shape clinical practice as well as research in the coming future. And who better to tell us about this than Dr. Nipun Verma and Dr. Janen Shukla. I'd also like to invite the panelists, Dr. Arun Valsan and Dr. Ashwini, to join us on the stage.
Good morning, everyone. The first talk is by Dr. Janendra. Can you shift over? So I welcome you all for this morning workshop in INASL. And the first talk is about how we communicate with the language of artificial intelligence with clinicians. So this is going.
Hi everyone, a very good morning, and quite early I think I must say. But yeah, glad to see there are some faces that we can see. Perfect. So I am Jainendra, and currently I am an associate at IIIT Delhi. I completed my PhD from URV, Spain in robotics. So I have been working in this domain since let's say around 17 years now. So I have a 17 years of experience altogether in AI, ML and DL. So I will try my best to demystify it, and let's begin. And also, I mean, please feel free to interrupt me at any point of time if you think, I'm not getting clear. Perfect. So how many of you know these faces? I mean, do you recognize any of them? I mean, come on.
They got the Nobel Prize last year.
Yeah, perfect. So they all are Nobel laureates and in different fields. So these two, John and Jeffrey, they got the Nobel Prize in physics. And Demis and John, they got the Nobel Prize in chemistry. But apart from the fact that they both are Nobel laureates, there is one more interesting fact here, that none of them are trained physicists or chemists, by that matter. I would like to repeat that again. None of them are trained physicists or none of them are trained chemists, for that matter. Still, of course, they got the Nobel Prize in their different respective fields, which is not so uncommon. But again, other common factor to both these groups was the use of AI or the advancements that they use in AI to reshape and redefine the field. And so the idea is just to motivate you that, of course, I believe many of you are already excited about AI and potential of AI, but this is the reality that is happening out there, and I'm pretty sure the physiology and the medicine could be next, where a person who perhaps is not even from the field is going to win a Nobel Prize in the field by doing some really great advancements. Perfect. So with that tone, let me just begin. And at a broader level, of course, the bigger question is, what is AI? Of course, I mean, I don't have to explain what is intelligence. We all are human beings, so we understand a bit about intelligence. Loosely speaking, on the basis of that, the idea of AI is the systems that can mimic the intelligence of the humans, as simple as that. And altogether, this intelligence involves learning, reasoning, and making decisions. So this is what the AI is all about. Now, the important thing to note down here is that there are many ways to create systems which can be artificially intelligent. So there are many ways to create systems which can be artificially intelligent. Here I'm just listing down 3, there are many more in fact. So for example, there is rule-based systems, statistical pattern recognition kind of systems, and neural inspired models and all that. And I will just try to touch upon all these briefly, and then quickly we will arrive from what AI is, what exactly ML is, what exactly DL is here. So having said that, what AI is, how can we achieve, there are many different ways of achieving AI. Let's just touch upon the rule-based logic. I'm pretty sure many of you may already have come across these terms, right? Inductive reasoning, deductive reasoning, and in your day-to-day practice also, I'm pretty sure that we all apply this inductive and deductive reasoning. So one very simple example of how to formulate this rule-based logic is this. And please don't get scared by this quote if you do not understand this modus ponens. Is it a familiar term, modus ponens? I'm not sure. No, it's not familiar. Okay, nevertheless. So the quote is very simple, the modus ponens. And by the way, it's from the Socrates time. I mean, perhaps it was codified by Socrates. So the idea is very simple. If P implies Q and P is true, perhaps Q is also most likely be true. And you may not know this, but you already do this kind of deductive reasoning such as this. So if a patient has jaundice, they likely have liver dysfunction. P implies Q. So P is patient has jaundice. They likely have liver dysfunction. So if the patient has jaundice, P is true, most likely the Q is also going to be true, which is the patient likely may have the liver dysfunction. Am I making sense so far? So this is just an example, and this is an intelligent behavior. You were able to reason about it. I will repeat again, this is an intelligent behavior. You use the rule-based system. Of course, you may not codify it, but in our day-to-day life, we use it regularly. So using a rule-based system, we showed an intelligent behavior where we were able to do what is known as deductive reasoning. So given a fact is true, if a part of the fact is known, perhaps what implies is also going to be true. Perfect. So this is just an example of how can you achieve a intelligent behavior using rule-based systems. Now, this is something that AI or the intelligent systems, I mean, we have been using this since around 60s, I would say, to create these rule-based systems to come up with the intelligent machines or intelligent systems. Expert systems and all that from 60s and 70s are the examples of this thing. Now, there are two big problems. I mean, of course, among many, there are two big problems of these rule-based systems if we want to create intelligent machines or intelligent systems with the help of rule-based systems. Number one, it's very hard to figure out the rules. I'm pretty sure you will correlate with the practices that you guys do, that I mean, not all the practices that you do can be codified in a rule-based logic, exactly like this, that like if P then Q, if not P then not Q, and so on and so forth. So not everything can be codified. So that is the bigger problem. And even if you can codify certain things, even the bigger problem is it may not be transferable. So for every other case, you will have to come up with a new rule. You will have to come up with a new logic. And I will, is it clear or should I give some example? Is it clear? So far, are you guys with me? Yeah? No one is sleeping? Perfect. So first way, so again, I will repeat. AI, we wanted to create intelligent systems, machines. There are many ways to create intelligent machines and systems. The first one is a rule-based system. There are limitations to it. So then what we decided to go to something that we call it as a data-driven AI. So from rule-based AI, now we are talking about a data-driven AI. So this is where the machine learning, let's say, typically comes into the picture. Formally, machine learning is what is a study of algorithms that can improve their performance in an automated manner. And this is very important to know. But before that, traditionally, I already talked about the rule-based systems. In a rule-based systems, what we do, as an input, we have the rules, P implies Q. Remember, as an input, we have the P implies Q. And then we have the data, the new patient, P is true. So if the patient has jaundice, most likely they are going to have a liver dysfunction. That is I think I cannot use my cursor here. Okay, so P P implies Q is here. Then P comes into that patient has jaundice. What is the answer? Answer is patient is most likely going to have liver dysfunction. That's the traditional programming through which we were trying to achieve the intelligent reasoning and intelligence systems. Now, in this new era, the era of machine learning, what we try to do is this. Okay. So in this new era, what we try to do is, now we have flipped the input and the output a bit. So what we take, please pay attention to this particular point. What we take input, the answers and the data, and then we give the output as rules. I will repeat again, and this is something that I really want you to pay attention to. We take the input as answers. What does the patient has? Liver dysfunction. What is the data? Patient has jaundice. And then it tries to figure out the rules on its own. Most likely they are correlated. If the patient has jaundice, the patient is going to have a liver dysfunction. So the idea for the machine learning in a broader term is, it does not ask you to define the rules. It comes up with the rules on its own. And the way it comes up with the rules is it looks at the patterns, the data that it is already fed to. Hence it is known as data-driven AI. The more patients' data you give it to, the more it tries to figure out the rules in a better manner. Am I making sense so far? Yeah, perfect. Now, formally speaking, this the definition I want to just emphasize on the definition a bit more. That machine learning is what? Is the study of algorithms that improves their performance. Please pay attention to this particular point, because in the history of mankind there has been no system so far which improves its performance on its own, and that is what the beauty of machine learning is. Improves its performance P at some task T with respect to improves their performance P with some experience E. And now we will try to dissect this PTE in a bit more detail. So altogether, a well-defined machine learning task has three main ingredients: performance, task, and the experience through which it is improving the performance on a given task. Quickly, what exactly is a task? Task is basically the problem that we are trying to solve with the help of machine learning. And what are the examples of these tasks? And you are already familiar with many of these tasks. One such task is, for example, classification, as simple as that. Whether the patient has a particular disease or it does not have a particular disease. Classification problem. You are trying to classify, given whatever data you have, you are trying to classify, classification. Similarly, you do regression all the time. So for example, what could be a value of, I don't know, platelet counts in next 5 days. So this is a prediction, a regression task that you're trying to predict over a continuous value. So basically, the classification is categorical. You have some categories, and in the case of regression, you have a continuous value for which you are trying to make some prediction. Then you have clustering. Clustering, you do not have any idea at all about what the things are, but maybe you are trying to club them into some structure. So I mean, as simple as that, ACLF types. I mean, you have some data, and then you are trying to club them into, okay, can I club them into a group based on their ACLF types? I do not know what kind of behavior label that I can give it to them, but they have some different types. So this is the example of the different tasks that you may see from in your day-to-day life about with respect to the machine learning. Now, what is the performance? Performance is simply a way to measure how exactly you are doing, or the machine learning algorithms are doing on that particular task. And again, you have been using it regularly. And these are usually very, very task specific, such as in case of a classification example, I mean, we talk about all the time accuracy. I'm pretty sure like most of us, we already know about the accuracies. Accuracy is as simple as that if we have 10 patients, out of 10 patients, how many patients are we able to correctly classify and as who have disease versus who do not have a disease, accuracy. And then similarly, there are many other metrics. We will not go into the metrics detail. Similarly, when it comes to, for example, regression. Regression is again another type of task, but then you have a different metric. You do not use accuracy here. That does not make sense for many reasons. So we use something known as MSE, mean squared error. So what is that? Basically, okay, you have this platelet count. What the platelet count you predicted, what is the difference between that? I mean, as simple as that. So basically, performance is a way to help you understand how good the model is performing on the task. Am I making sense so far? Is it clear? Yeah, perfect. And similarly, and of course, as I said, I mean, so the most important thing about the performance metrics are, these are very, very task specific. So you have to define the type of the task that you are trying to do, and then you also have to understand what kind of metric is going to make sense for that. So what alternatively it means, if you were to take a classification task, you cannot use, or you do not want to use the mean squared error on a classification task, it will simply not make any sense. And if it will not make sense, then it will not have any value, the model or the thing that you are trying to do, okay? Now quickly I will try to talk about this experience. So there are 3 different types of machine learning that you do. One is the supervised, one is the unsupervised, one is the reinforcement learning. I mean, I'm pretty sure many of you have heard the name. So supervised is basically all about that here you have some sort of data that is available to you, and then you have certain answers available to you, right? So basically, what is the patient's imaging looks like, and what is the diagnosis that the patient have. You have both the information, and then you try to learn from that. In the case of unsupervised learning, what you have only the imaging that is available. You do not have the diagnosis available for the patients. In the case of the reinforcement learning, then what you have, it's altogether a very different setting. And for the particularly for the this particular scope of this talk and all that, I would not like to focus on the reinforcement learning, but in recent times, most of the advancements that are happening in AI and ML and all that are coming from the reinforcement learning. But just for the sake of the time, we will try to finish it here. So, Dr. Nipun, would you like to elaborate more on the next things? I have, but I think I'm not sure if I can try to cover all of them. So should I just cover at least the deep learning part of it? Maybe? Okay, so let me just bear with me for one more slide. So the idea is, okay, so far what we did, we started with AI. We said there are many ways to do AI. One is the rule-based system. We didn't like it. We moved to data-driven AI, machine learning. So now everything was working well. Why are we moving beyond to machine learning and deep learning? And this is where I will finish. So traditionally, when we talk about the machine learning, the way we do the machine learning is this. We take some data, and from that data, we also have to formulate certain features to feed to the machine learning system, so as to say that, okay, from this data, you have to look at these features. And I'm pretty sure this makes sense already to you, that when you want to look at, for example, if you were to give me an X-ray image, I mean, it's just a black and white image for me. As an engineer, I mean, it's just a black and white image for me. I don't know what it is. I don't understand what to look at. I mean, let me rephrase that. I don't understand what to look at. So you as a doctor, you as a specialist, you come in and then you say, no. In this, you have to look at this particular area. So that's what you are doing. You are manually handcrafting the features, and then you are telling the algorithm, these are the features on which you have to focus upon. And then focus on these features, give me what you want to do. So that's what the machine learning is all about. Now the limitations are, many times, the features are so complex that we really cannot understand that what features to even look at. There is some different new type of disease or something. We simply do not even understand what kind of features are going to be represented here, or the features are simply in very, very high dimensional data. What I mean to say is, you have imaging, you have lab data, you have clinical data, you have proteomics data, you have this data, you have that data, and you have to make sense of all of it together. So it's simply too much to handle. Let me just say that. And this is where the deep learning algorithms comes into the picture. So the whole idea of deep learning algorithms are, we are trying to get rid of the manual feature extraction. I don't want the humans to be here to tell me what features to look at. Now what happens with that? I may come up with a sort of set of feature that humans may not even understand or may not even know, oh, this was supposed to be looked at here. Because simply the correlation is in such a high dimension among all these data points that you have, that for a normal human mind, it's very, very hard to even appreciate that or understand that. That is one thing. That's the beauty of deep learning so far. So you don't really need the human expertise to do the manual feature extraction. And I think one should be scared of that you really don't need human expertise, means you don't really need the domain expertise. And the problem that it has is, many times it tries to learn the features which does not have any correlation, does not have any sense. So basically it learns the correlation, but it does not understand the causation. And with that, I would like to leave it here. Of course, I have some very fascinating story about deep learning that I will talk during the coffee and the breakfast break. So Dr. Nipun, over to you. Thanks.
Thank you, Dr. Shukla. Before Dr. Nipun starts, I just want to take a couple of minutes because I understand now from the that I was supposed to set a bit of a context here. So most of us here actually are familiar with classical statistical methods. Most of us have used this in research before. And part of why this workshop is interesting to us is to understand how we can use it better to understand our science. There are different models currently in which we have used some sort of AI or machine learning continuously. If you're using SPSS, it has incorporated into different parts of SPSS, especially in the newer versions. What's interesting right now, what is different is that there is multimodal AI, which can combine things that are not numerical, non-numerical, pictorial, to come up with insights and solutions. And as Dr. Shukla has already mentioned, there is an element of pattern recognition with unsupervised data, which may not be actually apparent to us. For example, lots of new AI studies have shown that even with ECG readings, they can predict the gender of the person. So I mean, there are patterns that are not intuitive to us, which can actually be picked up by AI, which makes it exciting. In hepatology and liver transplantation, we are using AI quite extensively in prognostication, in liver allocation, as well as in predicting things like tumor progression. So there are numerous real use case applications of AI which are already apparent to us right now. So sorry, the background came a little late, but I thought it was better that we did it before Dr. Nipun's talk. Thank you.
I think the next one is Nipun. He's going to talk about case-based discussions and how to use AI in cases. So over to you, Nipun.
Well, thank you very much. This part of presentation will focus on the clinical applications of artificial intelligence in hepatology. And I bring greetings from PGI Chandigarh. My job here is very simple, as Dr. Janendra has set out the stage, and Dr. Sonal has also mentioned that AI is revolutionizing the field of hepatology, and we are trying to make predictions for given diseases. It's not moving. Okay. So we have understood that there are three key components in any artificial intelligence process. You have heard about the perspectives from engineer. What I see as a physician or a clinician is that I have a data. There is something we develop upon, which is called algorithm, and I look at the output. And whether that output is correct, incorrect, I have to assess that through its performance metrics. And on base of everything, we have a computational power, the computation tools which we use. Taking an example, we have a structured data where we have different entries of a given individual, clinical variables, biological variables, let's say images. We feed into the computer systems, use certain algorithms which are deep learning or machine learning, and try to see whether the output which we are trying to predict is correct or incorrect. The examples in hepatology range from different sources of inputs, ranging from clinical, laboratory, radiology, pathology images, and not only that, the biological systems, that is the multiple omics we feed in. And now there are lot of revolution in large language models, which tries to predict, not only predict the text, which is there in the next sentence, in a given sentence, but also to generate, to reason, and to come with an output which can actually make a sense which is similar to a human brain. So this is something called natural language processing. And on top of it, there is a lot of applications on real-time monitoring, the biosensors, which we can use as a continuous input to improve our predictions over time. So I'll take you through some of the examples in hepatology which has been done. First example is through supervised machine learning. We have a data set, clinical variables, routinely available variables, and we are trying to predict, and we know what was the outcome of a given individual in that data set. We are trying to predict using routine clinical variables, let's say of patients with acute and chronic liver failure, to predict whether the person is likely to survive, whether he is at high risk of mortality or low risk of mortality without transplant. So this was a study from a INASL consortium led by Professor Sareen. Dr. Shukla is also here, Dr. Ashok is also here, who led this study with us. And this algorithm helped us understand the risk of mortality in a given individual with acute on chronic liver failure. And we know acute on chronic liver failure is a condition with high short-term mortality, about 50%, and it ranges from 15 to 50%. The dynamicity is such that patients' presentation and trajectories over first 7 days are very important in predicting the outcomes. That is the domain knowledge we have today through statistical algorithms. But how AI can improve our predictions was employed in this project. We took clinical variables, several of them starting from lab values to clinical presentation, nothing beyond that, nothing fancy, nothing biomarkers, just routinely available data. And you see the predictions, the prediction in terms of high risk of death. And since this is the classification problem, we could ascertain that the discriminative accuracy which we see through AUC, which is called area under ROC curve, was much higher compared to the traditional algorithms which we use, which we call it as ARC model or the MELD score calculated at day 7. So this performance was much better, about 12.8, 13% better, ranging up to 90.7% compared to 80% with MELD score or ARC score. And second metric we always see when we look at the output of machine learning model is the calibration. That is how the predicted probabilities from a given model fares or correlates with the observed probabilities. So here the observed probabilities, that is presence or absence of disease or presence or absence of death in this context, is converted into a observed probability scale through log odds, and the predicted probabilities on x-axis and observed probabilities on the y-axis, and you plot out. And there are several other metrics for calibration, which is a numerical difference between observed and predicted probability, which we call it as Brier score. These are the two common metrics which are used. Then there are several others, R square and other things. Apart from that, the discriminative accuracy which I told, the AUC, the calibration, the second performance metric. The third metric which we commonly employ in any prediction algorithm is called decision curves. I'll not go into detail, but decision curves is something where we try to say whether taking a decision based on the outcome of a model, treating all patients based on that decision or treating none of the patients based on that decision, how does our model performs over a range of predicted probabilities. So using this algorithm, we deployed this algorithm through decision tree models, and we could extract the top performing model, that is extreme gradient boost. We could extract the top decision tree which was making an importance, and based on the creatinine, circulatory failure, and the INR values at day 7, we could classify patients into high risk, low risk, and intermediate risk. And this can easily be employed in any triage area in the emergency to put high-risk patients into ICU, low-risk patients into wards or on OPDs, and intermediate risk to be clinically evaluated by a given physician. Then a more precise tool, the AI tool deployed on web application was developed, and this tool is so devised from extreme gradient boost, broken down to only 10 variables at day 7 or day 4 to predict outcomes with 90% accuracy. Now coming to the unsupervised part of machine learning, unsupervised machine learning is a process where we try to cluster or group individuals based on the data characteristics. Again, I will take the example of acute on chronic liver failure here. We took patients with acute on chronic liver failure of any definition and tried to group them into different clusters based on the data characteristics without giving any information that whether the patient is surviving or not surviving. So we devise certain clusters, we'll look at these clusters, we explain these clusters, what are their clinical characteristics, the lab characteristics, what were their outcomes after developing the algorithms, and then we use supervised part of machine learning to predict those clusters. This is called integrated approach of machine learning. And here what we saw that two definitions which are commonly employed for any ACLF population. Can you see my cursor? Okay. So if you see that APASL, EASL are the two commonly employed definitions. The survival based on these definition, pure APASL has 70% survival at 30 days. EASL has 30% survival, and both APASL and EASL has 50% survival at 30 days, but which was better classified through latent class model, which used inherent patient characteristics to group these individuals into 4 different clusters. And cluster 4, which was the highest risk cluster, you could see that these patients had the maximum severity, with CLIF-C OF score in majority being 11, 3 or more organ failures, and these were the patients with multiple acute insults. So unsupervised way could understand that what are the high risk patients. Clinically, we also know all of these characteristics, but data without any prior knowledge or a prior knowledge could also identify these variables as a high risk individuals. But when we ascertain risk in a clinical world, in a clinical scenario, we try to see individual characteristics on its own. Whereas machine learning looks at the patterns or the connections between different variables and try to put them at different clusters in unsupervised machine learning. In cluster 1, we could see that these patients were pure alcoholic hepatitis without underlying cirrhosis, without multi-organ failures, and they are likely to survive. Cluster 2 or 3 had intermediate survival about 50%, and these individuals should be looked over time, first 5 to 7 days, how they are behaving, and then if these patients are not improving, these patients are likely to be counseled for liver transplantation and other experimental therapies. Now we all know that how machine learning is performing and how it is predicting tasks through supervised and unsupervised way. But there are problems of understanding how these machine learnings are working. What are the key processes inside the machine learning tools which is making those predictions? And we traditionally we call that all machine learning algorithms are black box, but that's not true today. Lot of research has undergone into the explainability of machine learning models. Several tools are available now. Global explanation means that we try to explain the overall process of machine learning through key variables and in a descending order of their importance. Whereas local applications mean local, explanation means that a given individual with certain characteristics, how machine learning is behaving and how machine learning is giving an output. If we understand that, let me give you an example. Let's say a person with ACLF comes to us with alcoholic hepatitis with 2 organ failures, liver and coagulation, and that liver and coagulation failure worsens over first 7 days. The bilirubin jumps from 12 to 30, and the INR jumps from 2.5 to, let's say, 3.5. So this delta increase was important in making an important prediction for the patient's outcome, that is the mortality. That if we could ascertain without giving a priori knowledge to a machine learning tool, this is called and we are extracting that information through a machine learning process. That process is called local application of any machine learning tool. So here I want to give an example of a random forest model, which is a model developed on non-alcoholic fatty liver disease patients across Go Asia Consortium. This study was led by Dr. Duseja, and this study actually helped us understand how we can rule out significant fibrosis. A significant fibrosis, we all know, in fatty liver disease is an important predictor of poor outcomes, not only liver but also the cardiac outcomes. So looking at the importance of the model, so this random forest model, we understood that it performed much better than FIB4. It had 10 times higher odds of diagnosis of significant fibrosis. It could reduce the unnecessary, and in a virtual environment, it could reduce the unnecessary referrals by 28% and prevent the missed referrals by 78%. So when we try to look at their importance, the explainability, the components which are there in the FIB4 score are already there on top of the feature explanation, that is the AST, ALT, and the age. But important thing here to note is that HbA1c popped up at top 5 variables. So what does that mean? That means that control of diabetes, apart from just presence of ascites, is very important and critical in determining whether a given person is likely to progress to significant fibrosis. This is just an example, simplest examples from the initial days of AI in hepatology. Now, AI tool could also help us understand that to rule out significant fibrosis, we can use different scoring systems such as SAFE score and FIB4. And if we can use these sequentially in a decision tree format, that SAFE less than 140 and FIB4 less than 1.2, it was quite accurate, about 85% to rule out significant fibrosis, whereas FIB4 performed really poor in terms of performance, that is 65% accuracy. So this was an explainable component of any artificial intelligence models. Now coming to the images, and we'll deal with images and hands-on demonstration how images can be used to predict certain outcomes in hepatological disorders. Traditionally, the AI tools are used to either segment a given area of abnormality in an image, or to classify whether a disease is present or not. Let's say you took an example of CT scan image, liver at L1 vertebra, you took a cross-sectional image, and you tried to use deep learning algorithms, which are machine learning, advanced form of deep machine learning algorithms, to say whether this is a tumor, whether this is a FNH, whether this is an adenoma. And then there can be another problem which can be solved through AI tools is future occurrence of event, that is the prognostication, whether the person is likely to survive or not. Or it can also predict, if we have a data set, combined data set showing that image and then a procedure done, let's say TACE, and then we have an output that is response to TACE in a given data set. We can match the baseline image to the outcome, that is the response to TACE, and then we can predict based on the baseline features in the image whether the response to TACE was there or not through a deep learning tool. And now if you have a new patient coming in, you give that image to that tool, and then you will understand whether this patient is high likely to respond to a TACE or not. So these are the certain examples on images and AI. Several examples are existent in literature to decipher whether there is secondary or primary sclerosing cholangitis on MRI through AI. This is very important example. I'll just take 1 minute because images are so important. The things which we cannot see through our naked eye can be seen through deep learning algorithms brilliantly, without any fatigue, and with several iterations, without even getting low on the accuracy, which human brain often does over the period of time. So this study, looking at 45,000 images, could predict the degree of portal hypertension, and these tools are open source. We can use an image, feed into computer to get the degree of portal hypertension, that is the HVPG. The accuracy was about 85 or 88% in this study. And as ECG was mentioned, ECG is revolutionizing, I would say. The cardiovascular medicine has taken a leap. ECG is shown to computer to predict not only the cirrhosis, but also to predict what is likely to occur over next 5 years in a given individual, not only for liver related outcome, but also the cardiovascular outcomes. A huge task, huge work going on from Mayo Clinic, and you will see a lot of publications in near future. Now coming to last to the endoscopy, we have seen endoscopy, polyp detection, the colonoscopy guided adenoma detection. But for hepatology, varices and varicose bleed is very important because these patients are very at high risk of mortality if not adequately controlled. So presence of varices, if shown to a computer vision, which is a specialized form of deep learning algorithm, we could predict in this study the risk of bleeding and whether these models perform better than a routine clinical physician or trainer, the trainees, and in this study they could show that this algorithm performed better. Now there are several applications on pathology to look at the slides of histology to determine whether there is a presence or absence of a cancer, the heterogeneity within the tumors, and even to the cellular level we could predict in nuclear atypia or micrometastasis. In this example, the histology slide was used to predict response to tropifexor, and compared to the conventional microscopy or a pathologist guided response to fibrosis regression was 17% with tropifexor 200 microgram, but when used through AI algorithms, they could see that the response was much better, and this led to the approval. Now, images can also be used, histopathological images or radiological images, to predict what is the genomic profile in a given tumor. This is coming up in a big way in oncology. We have a data sets, open source, and then you can use the algorithms trained on open source data in a wide amount of data in your own data sets, smaller data sets, to predict what is the likely genomic profile. And this could help in ascertaining the group of hepatocellular carcinoma or any carcinoma into different risk categories. In this study, they showed the HCC images can be fed into AI algorithm to predict what is the likelihood of gene signatures, let's say T-cell exhaustion, where we can use immunotherapy. So these are some of the examples. Omics is also employed with deep learning algorithms and machine learning. One of the tasks with Dr. Arun is involved is in proteomics guided infection detection. And we will talk this more about this in infection talk during INASL, how we can use proteomics and artificial intelligence to predict whether our ACLF patients are infected or not infected. LLMs is a different task altogether. It is coming up in a big way for predicting that next sentence or token in language, which can reason as well. Lot of applications coming up in a documentation, the EHR, summarizing the clinical clinical conversations with the patients, and then image interpretation as well through language-based model, which are vision language-based models. These are also used as chatbots to talk to the patients, talk to the physicians, give answers based on the existing literature, and reason as well. And we will talk more about it during the discussion session. Apart from decision support systems in biomedical research, BioMini, BioLLM, several of such applications are now available to automate the analysis of a given data set in a given computer. And agents are nothing but combining different large language based models together, and which can also automate the whole process of AI, reason, take actions, and even correct them. So agentic AI is also coming up in a big way, and the future is ultimately to look at the data sets from different sources, web, the larger data sets available as an open source. And what we see in future is likely this, a dashboard where a patient, Tony Stark, is there. We look at their clinical variables, integrate AI models into that whole process of electronic health record, give recommendations about treatment of individuals through AI tools, and then physicians take decisions for that individual. And if anything goes wrong in that decision making, the AI tool can alert that this decision is wrong. And this is one of the examples which I would like to say, that Panda AI is something which has, it's in Kenya. So the AI tools through large language based models have been integrated into health system to, as a safety net to prevent errors in medical documentation, to prevent errors in medical decision making. So there, what they have done is integrated the large language based models with EHR system, And if a physician is giving a particular, recommendation for a treatment or not giving a particular recommendation, the system is alerting that yes, you are right, or no, you are wrong. So false positives and false negatives are detected through these AI algorithms. And in this study where Google-based, AI algorithm has been integrated with Pandas Health, which is a health system in Kenya. So there they showed about 30 to 40% error reduction in the clinical decision making through artificial intelligence models. So I would like to thank you all for coming here. And now we'll go on to the last part, which is basically a demonstration of how image can be used to predict a particular outcome, that is presence or absence of disease. We have Vinay, who was a PhD student. We have Dr. Ashwini, assistant professor from IIT Ropar, and Dr. Janendra from IIT Delhi to take us ahead. Thank you. These 4 clusters were predicted, and these 4 clusters were put into an Excel format of same individuals. Okay. Now you know that there is a cluster information available for those 5,000 individuals. Now you use artificial intelligence to predict those clusters. Okay. The variables which were given for clustering did not include the outcome data, which is a patient's outcome or severity. We just gave the routinely available clinical variables and trajectories maybe over first 7 days, and it grouped the individuals into 4 clusters. Now when we use the outcome data within that data set, it could ascertain that clusters had different outcomes. Now when we have this data, we can use integrated approach, and this has been done. Several papers are available in Nature Medicine as well, using this integrated approach where we can use this information of clusters and predict the clusters through the baseline data. And that study we showed that using the information at baseline and first 7 days, we could predict these clusters. Now the implication is, once you go to a next individual who's coming in OPD or maybe in ICU, we can make a prediction about a cluster and see its outcome. And whether we can use or take decision based on that information is a second step altogether, which is an implementation AI.
Okay. Then one more question relating to this is that how do you decide that which variables are you going to put into it? Of course, one is your clinical decision and the routine practice. Because say like you have a regression model. Okay. Now the regression model gives us an R square. So the R square will explain the amount of variability occurring through the variables that we have put in. Now if it is sometimes not very powerful, say if it is 0.28, okay, so that means there are certain variables that you have not taken into account. So ML is not going to tell us which variables we need to put, right? So that is our decision. So how do you decide on those things? Because garbage in and garbage out.
Exactly.
Right.
So Dr. Janendra would like to say about feature selection and...
Yeah, so, okay, I'm audible, right? Is audible? Yeah, perfect. So, I mean, excellent question. You and I particularly like the phrase garbage in, garbage out, because this is something, this is my go-to phrase. My go-to phrase anywhere, garbage in, garbage out. So really you have to understand that. Now coming to the question, how do you decide which features to use? Of course, I will not say which features to use in a clinical setting. In general, how do you decide which features to use is driven by this. First, you look at the theory. You look at the literature, you look at what is the evidence that is available. And that's how you start. But please pay attention here, that's how you start. Because if for example, and I think, of course, I may be wrong here, but for example, COVID-19, when there was this case, when happened this 2020-21, there was this thing that based on the chest X-ray images, the community wanted to predict COVID-19. Can you do the diagnosis of the COVID-19 based on the chest X-ray? Of course, I don't have any knowledge, but I don't know what features you were supposed to look at that time in the chest X-ray in order to do the diagnosis of the COVID-19. so of course you will be guided by some philosophy that okay, you know, like okay, by my clinical practice, the training, I mean, I know that these are certain things that I need to look at, I know, boom, 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 which of course as an engineer, as I said, I mean, it's just a black and white image to me. And you start with that, and ultimately you will see the performance metrics, you will see the results perhaps will not come out as very good, and that is where you will realize, okay, perhaps the results are not coming out to be good, then I need to blend in the deep learning here, and I need to look at if there are any more features that I'm missing, and so you gradually keep on moving further. But more importantly, at the end of it, even if I would say the other problem is, even if let's say you are getting a very good accuracy, let's say the R square in your case maybe you are getting 0.9, then also I would say you cannot really assume that if you are getting a 0.9 of R score, the features that you used are good enough, are good, or like were good, or for example, even let's say you used a deep learning based model to get the regression score of 0.9, then also you cannot say that the deep learning looked at all the relevant features. And this is exactly the thing that I wanted to quickly talk about 2 minutes, and I think then we will go to the demo. So in this particular problem, and this was a real problem where the community wanted to predict COVID-19 on the basis of the chest X-ray images, and this is exactly what happened. They, I mean, I am not sure, they means where was exactly the medical community or the researchers, the engineers together. I mean, they came together. It was a case in, it was the case study in Italy actually. I think some of the first cases of the COVID-19 came in Italy, where they had these X-ray images and all that. If I'm not wrong, of course, you guys know better. So basically what they did, they had this data of the X-ray images, just X-ray images. They wanted to see if the machines can do the automated diagnosis of COVID-19. And ultimately they saw that there was excellent performance. I mean, the accuracy was 0.9, the F1 score of was 0.9 plus, and they were very happy. So when they started deploying or testing it on some other countries, even in Europe and outside Europe, including Latin America and Africa, I don't think they deployed it in India. The accuracy was like horrible. Then they said, what happened? Then they tried to see what exactly the feature was getting learned there, because they wanted to do the dissection, as Dr. Nipun was saying, that now we have to, there are tools available that you can look into it, like what exactly it is learning. Of course, as you rightly said, features we never knew, so we said, okay, you learn all your features, you create your own set of rules. I just need the performance. I need performance of 0.9 plus. And then ultimately, you won't believe what the community found out, the researchers found out. They found out that these deep learning models, to do the diagnosis of COVID-19 from chest X-ray images, was looking at the presence of the pacemaker. I will.
Yeah, or the central line. So some of these.
So and the reason it happened, I mean, of course, you may study some of the early patients of COVID-19 that happened in Italy, or at least for whom the chest X-ray images were available, they all were elderly. Most of them were elderly. Of course, COVID hit the elderly
But
patients.
not
So
everybody would have a pacemaker, right?
A
It's
central
not a very
line,
common
central line,
feature.
central line.
central line.
Yeah,
perhaps,
it inferred that they were sick.
Yeah.
So I just have one question there actually, because I think Bayesian probability is probably is gravity for all these models, isn't it? I think that population prevalence determines everything.
Yeah.
If you're looking for COVID in a chest X-ray at the time of a COVID epidemic, the population prevalence is 70%.
Yeah.
You could toss a coin and be right 50% of the time,
Yeah.
right? So the problem with all these models, at least in the COVID time, was that they were not accounting for population prevalence.
Yeah.
Now today, at that time in the middle of the COVID epidemic, if we took something and we put it through a scanner, we diagnosed COVID, we'd feel pretty good about it. But today, when there is no COVID around,
Yeah.
if we did it, how would our models perform?
Yeah.
Because that is probably the bigger question to ask, isn't it?
And lastly, to just summarize, how do we select features? Apart from domain expertise, there are several tools available. If we use data-driven approach, apart from domain expertise, we have feature selection algorithms ranging from random forest-based wrapper algorithms called Baruta. Then you can have feature selection based on the employing a feature explainability component of any machine learning process. Let's say you take a feature importance values, you employ a tool, you predict, and then use that tool for explanation and look at the top features which are explaining. To take those 5 or 10 features to use them for making predictions. Apart from that, there are several other ways of excluding features which are correlation based. So you do correlations. Those who have high correlations, you exclude some of the features, you keep some features. Then apart from that, there are other ways of penalizing. Let's say you take logistic regression for predicting an outcome, and you use lasso or ridge regression to concise the parameter estimates and reduce the number of features. So feature selection is a and feature engineering is a separate term where you try to devise new features from the existing features. Is a really core of any machine learning process, and it can improve the accuracy from 80% to 90%.
Yeah. So one last question relating to this only is that I totally agree that feature selection is a separate thing, and it's a very deep thing where you remove all the superfluous material and that you don't want. But the primary thing is that whatever variables that you put into it is purely based on the judgment and clinical experience or of the person who's trying to do or use AI in the data, right?
So I would say the tasks which are complicated and at high risk of, let's say mortality, you cannot use just any feature, right? It's a very important and a critical task. For business people, they put in a lot of data and then feed to deep learning algorithms to make predictions with best accuracy. But for a medical task, we need explanation. Domain expertise is very important. Now people are using multimodal data sets, not only images, but other like ECG, I have mentioned one, omics, as well as images, then patient's history, and then routine sensor-based data sets, looking at their heart rate variability, let's say. So if we put lot of features, the deep learning is a beautiful process where even without telling which feature is important, it would extract embeddings out of those features and give us the best predictions. But the real problem lies with the deployment. When you look at the number of features required to predict a particular outcome, in a real world, it becomes really a challenge. So that challenge we have to bridge. And I think I will not take time, we will just carry on.
So I'll clarify it because I understand what the question and why it is coming. The thing is, the starting point has to be based on the available data and the experience. But that is, you have to have hypothesis. So that is how you start. But the beauty here is, it's a continuous process and you're keeping on refining. So your output becomes the input for the next, output becomes the input, and that's how you keep on learning and you keep on improvising, keep on adding more data. That can be proposed by the machine, it can be proposed by you. I think it's both ways.
Just to add one point to that, for machine learning model, maybe it is a voice data or it is an image data, it is just some pixels for us. So initially, if it is, there are two approaches as Dr. Jainendra as well as Dr. Nipun has told. Machine learning approaches which are more explainable, and second is deep learning approaches. In machine learning approaches, you give this set of pixels to it, and using domain expertise, we can define some of the features. We can use filters or we can extract features which are correlating to the domain expertise or like what you want to look at in a, say, X-ray image. And then you prepare or engineer the features according to the domain expertise. Then out of that, based on correlation, based on the importance that it is playing in the final outcome prediction, you will do feature selection or maybe some feature elimination as well. And this is what goes into the machine learning model for classification or regression or whatever task it is. But when it comes to a complex task where it is very high dimensional and engineering those features or bringing out that intuition that experts have into corresponding features, then we go for a unsupervised learning technique or a deep learning method, not unsupervised, sorry, for a deep learning method where we let the system learn its own features. Of course, the problem there is the point of explainability, but now AI is also advancing in that area where explainability is also there in, like it could be explained, the model decisions could be explained to some extent, but a long way to go ahead.
I am Rajiv Khanna from Pediatric Hepatology ILBS. I have just a basic question for clinicians. So when these deep learning models are applied for outpatient or for emergency basis for diagnosis or for triaging patients, so what are the legal implications? So when the prediction is failing for a particular patient, so what are the legal implications?
So as of now, these algorithms are not FDA approved or CDS CO approved. These are in research domain, and legal implications is a whole new world. And Dr. Sonal, would you like to say something about it?
Do you want to talk about the chart statement role here, or regarding the applicability of chatbots in LLMs and?
Chart is a new initiative where they have come up with set of guidelines for how to report, how to interpret chatbots for making clinical decisions and in a clinical workflows. The legal implications obviously include first the validation of that tool in that environment and whether that is approved by regulatory authorities. So always and always there is a human in loop. Human is, as a clinician, we are given that in output from that model. It is up to us how we use that information. So the liability lies not only on clinicians but also on the developers who have developed the tools. So it's
now there are two cases against discharge AI and triage AI in US. So discharge AI was discharging patients earlier than safe, and that's a big class 1 action suit against that app. So it's still.
Ability is still ours, actually, to be honest, and so judgment is required. But there are tools like Chart which are going to be helpful in the future, because you can actually judge the efficacy of specific LLM chatbots in how accurate they are.
Just one last question. I would like to understand your, like if you would like to comment on application of AI in tumors. So we just saw a few images, like few studies wherein some sections of tumor have been studied. So if we take a tumor as such, say for example 5 centimeter lesion, and we have taken, like we as pathologists we would have processed multiple sections, but when we provide inputs to the AI model to develop an AI model, we will take few sections. So that few sections, when we digitalize it, and based on that we are going to build the model. So if it is a core liver biopsy or something, the whole tissue that we have has been already digitalized and we have the entire tissue. But when it comes to a bigger tumor, there will definitely be some amount of selection bias in terms of what areas we have taken and whether that would have, so basically, for example, immunotherapeutic markers or therapeutic implications would be wide, but that tumor heterogeneity we will not be able to account for.
Exactly. So the point is very well taken, madam. This is an important question, what data we feed in, whether that is representative of the disease condition in context.
No, Nipun, that is now whole slide image scanner. So that is going to, whatever the sections you have taken, that will take everything, then will analyze. So that has been gradually being addressed also. So
whole slide images, when fed to computers, for AI algorithm, deep learning algorithms, they use advanced tools. One example I would like to give is patch-based learning. Divide the whole slide images into different patches, random selection of those patches for training the models, and then using that as a tool.
So, can I go ahead then?
Yeah, we have till 8:50. We have the time.
Nupun, what I can judge from the audience is there are two types of audience that we have right now. One who want to understand when they read a study which says that AI this thing, and they want to know how they can actually put this into use in their actual practice. That is one group. And there's another group who probably wants to work on this and be a part of the development process. So I think I would request you to tailor your next talk based on these two types of audiences. Make it crisp, and let's have some more time so that people can ask questions.
Perfect. Yeah, yeah. So I think, of course, I am really happy to see the engagement there. So one thing we have prepared the demo is like 5-10 minutes demo where we would talk about this. But before the demo, I just wanted to talk about this. Like the entire pipeline itself, which I think some questions were emerging from there. So the whole idea is that I think my cursor is visible. No. Okay. So no. Why are you touching this? Perfect. So, so you have to, first we have to understand what the pipeline looks like for a AI assisted solution, as simple as that. And then of course, what is the role of the clinician there, and then how we do that. So of course, everything starts with the data collection. And as I think one ma'am rightly said, garbage in, garbage out. If you do a poor data collection, if you figure out that the data itself is of bad quality, nothing can be done. As simple as that. Everything stops, don't look further. It's as simple as that. And you cannot blame anyone else there. The data quality has to be of utmost good quality, and that's where everything starts. So basically data collection is the biggest thing. Once the data collection is done, then precisely I think someone was, ma'am was asking about the feature engineering. Then comes the part of the feature engineering. Now of course, if you are doing this machine learning based methods, which frankly speaking for your purpose most of the time also would suffice, then you also would like to understand that, okay, what are the features that I as a clinician look at, and then hence you want to tell this to the team that you are working with, that okay, these are the features that I like to look at when I do the analysis of this particular disease or whatever. So this is where the feature engineering comes into the picture. So basically you start with some set of features, and then perhaps, but I don't know, maybe I have a hypothesis that this can also be looked at. I don't know what other things could be looked at. You can always do that, but this is the feature engineering part. Once the data collection is done, once the feature engineering part is figured out, assuming it's a machine learning based model, then the actual training of the model happens, which could be, of course, there are many different types of training that happens, which we will not go into that, but I'm just wanted to give you the entire pipeline. After the model training happens, then of course the evaluation comes into the picture, right? So basically you evaluate, and then you say R square is very bad, accuracy is horrible, F1 score is this, and this is way off the chart, this is this, this is that. Then you go back again, you look at, and then you gradually go back. Please pay attention here, you gradually go back. If your performance is not coming out as to be what you expected, then you do not go to the data collection directly. No. You look at the performance evaluation, and then you go back to the model training first. You do many other iterations and still if it's not to your satisfaction, then you go back to one step back, feature engineering. And then even if it is not working out, then you figure out the data itself is of bad quality. Because please pay attention that there is a huge cost also involved at each particular step, and you simply, and for the same reason, I'm pretty sure you guys collect more data than us, but when we try to collect the data, we try to make sure that, okay, this is something that we are going to do very seriously, because we don't want to come back to this stage again, where we have to recollect the data from 100 patients and this and that. So we want to be very, very, serious about this thing. So this is what the rough pipeline looks like. So once you have the evaluation, it's up to your satisfaction, then you talk about the deployment of it in a real world setting. Once the deployment is done, that job is not over yet. Then you talk about this monitoring and the maintenance, how the model is performing in the real environment. Now we are getting more data. Can we add that more data to train it even better manner? And so basically now it's a continual learning process, right? For example, the way ChatGPT is doing now with all of us. So basically ChatGPT is already there. We use it, we give it the data, and then it is getting trained in like in turn again. So basically also just the thumbs up and thumbs down is there. If you remember, just by that also you are retraining the model itself. So basically model itself, after getting deployment, it is getting retrained. So basically this is how the entire pipeline looks like. And again, coming back to the deep learning part of it, this is where the feature engineering plays a very minimal role. You do not really bother too much. Deep learning essentially is you tell it, okay, this is what the different types of data that I have, which could be multimodal, I think sir said, which could be multimodal data. You have tabular data, you have structural data, you have imaging data, you have electronic health records data, you have lab clinic data. I don't know what else. I'm really short on that. And then you simply put it there, and you say, of course, you say that, okay, this is what all the data that I have. I want you to figure it out. How can I do the diagnosis of the disease? And most importantly, it will do after following this pipeline. But then you want to come back and you want to see whether I'm looking at just a correlation, or whether there is a causation. Sometimes that causation is already existing in the domain. Sometimes you may come up with a new set of causal relationship that was not even known, and that is where you get to a discovery which could be worthy of like a Nobel Prize and all that. So with that idea in mind, I think I will quickly go to the demo part. So the whole
Dr. Janendra, I think due to short of time, what I propose is we create this as a video, or a module, and then perhaps, because we don't have time, we have just 5 to 6 minutes left. So I think we make this as a video available to all of you. Just send us Maisha or me an email. We'll create a group. We have already created a WhatsApp group, and we'll shoot this video, take questions regarding the video later on, because we need to discuss, as Dr. Akash sir has mentioned, there are two type of audience here, who want to develop and who want to know the process. So those who are interested in developing machine learning tools with collaboration, please raise your hands. Those who wish to know more about artificial intelligence in hepatology and the whole processes, please raise your hands. So we have 50-50% division here. So for developing new tools on artificial intelligence, the idea is to connect with the engineers. There are engineers here. You will find in your locality, in your IITs, you will find collaborations. But here is a good start. You can talk to Dr. Janendra, Dr. Ashwini. All of us will facilitate from INASL the projects if you wish. So you can put in your questions, start generating your data. It's not only your data, because now you have language-based models which are trained, very well trained on huge and billions of data points freely available. And you can also use something called as transfer learning, where the pre-trained models can be fit into the smaller data sets. One of such example is, let's say, electronic health record data set, which is developed through Stanford, which is called EHR short. This data set is trained on billions of patients who are admitted in ICU to look at their outcomes. Several of such data sets are available, and pre-trained models are available to be fit into your own data sets, which is called off-the-shelf models. So write to us, write to any of our chairpersons. And sir, would you like to have any other discussion point?
A good summary. I think Dr. Akash actually hit the nail on the head, because we have two distinct groups here. One is a group that's interested in the analytics and in learning about the nuts and bolts. The others are the applied group, which are interested in how we can use it in clinical practice. Perhaps a little bit more granular approach would be better in the for learning.
To have a AI workshop within 30-40 minutes is really so challenging. We cannot complete each step, but this is just a primer for all of us. We will have more sessions hosted by INASL and LTSI together. And Dr.
Nipun,
Akash.
I have a question again. When I read a paper, which is published in, let's say, JHEP, which says that, okay, AI-based learning tool which predicts model for outcomes of ACLF, or let's say our paper which we published. Now, as a reader, how does a person take it forward? Because you don't have that algorithm with you. That algorithm is not published there. That algorithm is not in public domain. So as a reader, as an audience, what is the utility for me of that paper?
Okay, so there are two aspects to this question. One is the reportability. How do we ascertain whether the reporting was done to the extent which is recommended by the guidelines? So there are several reporting guidelines for AI tools. One of them for routine processes, tripod guidelines, tripod AI guidelines, and MI claim, minimum information criteria. There, the tier of the model availability is clearly mentioned as tier 1 to tier 4, where tier 1 is that the models are freely available open source, and tier 4 is not, where the models are not available free open source. Our study, we gave that algorithm as a open application where one can feed in their data and get the output. That algorithm is available on request. It is a tier 2 the transferability of that model. And regarding the how do we take it to a real world in a given individual? till the time a model is has got a regulatory approval, this AI tool, all these AI tools remain in a research arena as of now. Regulatory approval, you can use it in real world, treat patients based on them. That's what my take is. And lastly, I would like to request Dr. Arun Walsan to have closing remarks on ethics and AI.
Thank you. I have 5 minutes and I'll finish it in 4, hopefully. So, what are the challenges? Am I audible? What are the challenges? So, quickly, the biggest challenge is incorporating the AI software to your hospital EHR. And then there is lack of regulatory guidelines and the validation and reproducibility and generalizability of your model. That's the biggest challenge currently in using AI into your routine clinical practice. So, and there is a lot of problem in operability between and amongst the AI models. So, what are the ethical challenges? Well, there are many. Most studies published in literature have, bias against representation of minorities and women, and that has been highlighted many times in the last ASLD as well. And then the other one is like just explained about the transparency. There is something known as the black box. Most of the algorithms are not available to public domain. And about the other question asked about accountability and liability. So if a surgical robot makes an error, is the surgeon responsible or is the algorithm responsible? Then using these large data sets without informed consent, then safety and reliability, and the lack of human oversight, and also issues related with intellectual property rights and data ownership. There are various biases in AI. One is the sampling error, what the prototype garbage in, garbage out. Then there are historical biases, maybe blacks or some Asian ethnic community, Latin Americans were not included in the historical cohorts. Then there are measurement bias. Then what Madam alluded to as the feature selection bias. To quickly, there are many methods to eliminate that, like the wrapped algorithm, then using lasso models. Then there is something known as RFE. So these are all, advanced features. Then there is language bias, something you feed in English. If you search in Hindi, you may not get the same prompt. So, and there is something known as a feedback loop bias. So if you train the AI and then it learns on its own and then may give you, wrong feedback as AI keeps on accumulating data. So what are the future of AI applications in hepatology, in precision diagnosis and early detection of tumors, in pathology, in radiomics, etc. You can use it for risk stratification, especially in terms of tumor immunotherapy response, in mast cell fibrosis, etc. Again, in non-invasive disease monitoring, in therapeutic decision support. Then you can use it in population level liver health. So one interesting study was carried out by Dr. Nipun's team during the COVID epidemic, where people were all phoning PGI and spamming us with requests for physical consult. So an elegant study was done where we could tell exactly which patient has to come to the OPD. It was a very simple study, but then it had a lot of value. And then there are a lot of surgical and transplant innovation, like large data and how to allocate organ, to see the quality of the donor organ, etc. And earlier research of a drug and drug development used to take a decade, but now with a fibrosis model or a hepatocyte model, a lot of to and fro iterations can be made within the lab. So all these are exciting things that can be done in AI. So I close here and we can open for a few more questions.
Dr. Akash, any further comments? Dr. Sonal, any other?
No, I mean, this is obviously extremely helpful. Thank you, Arun, for that insight. It's tremendously exciting. Each one of those areas is an area in itself. You can probably spend an hour on each one. But any final questions from the audience or any queries, comments?
Yeah, please.
So my question is basically once you develop the RKI tool and for your paper XGBoost model was performing had the highest ROC and this model will keep changing. So across data sets, either XGBoost will perform better or random forest will perform better. So how does it matter to the individual patient when a model gives a 90% predicted probability of mortality with the XGBoost and a 70% predicted probability of mortality with the RF. So how do we address the conflict between two models?
Okay, so while during the validation phase, if we have found that XGBoost is performing well, we would not use random forest, obviously. So using random forest is not a question here compared to XGBoost. The question here is, if the output is 90% probability, are you going to take a decision? And what is that decision? Are you going to shift that patient to any experimental therapy or liver transplant? What is that? So decision making and decision theory is different altogether based on the output of a machine learning process. So as we were discussing the other day with Dr. Sonal, let's say a model gives you a probability of 50% mortality. Would you refer them for transplant? A 60% probability, would you refer them for transplant, or a 40% probability, would you refer them for transplant? Obviously for 90%, if have finances, the setup is there, donor is there, you would transplant, obviously, right? But a 40 to 60% probability, let me take you an example. The MELD score of 15 is taken as an urgent criteria for liver transplantation. There the probability of 90-day mortality is just 30%, 30. So it means at a probability of 30% mortality at 90 days, we are using that information. It's 20%. 20%. Yeah. So you are taking that information as a referral for transplant. Ask yourselves, what are we looking at? What probability? So another example, the prostate cancer. The probability of 5%, the PSA levels above 10 is taken as a criteria for routine screening of prostate cancer. The probability of prostate cancer there is 5% annual. So we are taking that information because it is a context dependent and the community dependent and the disease dependent. If the disease has a high priority, high risk, even the lower probability of the outcome, you would refer them for a definitive therapy. So let's say a person has a probability of mortality above 30% or 20%, I would give them the best of the care, look at their initial few days of trajectories, and then perhaps as a clinician and surgeon together, we take a decision for
Yeah, I think that's very well put. That's context driven. For example, just as an extrapolation of the same, I give you a situation where the treatment carries a mortality of 10% and the disease carries a mortality of 15%. Would you offer the treatment or would you not offer the treatment? So it is all context driven. The machine cannot take these decisions for you, because ultimately it will give you the output that it is supposed to, that this is the probability. But what to do with that information at today probably is your judgment. Maybe after 5 years, 10 years, with further refinement, it may tell you that this is what would be the safest option. And ultimately, that also will also be contextual, because there are people who are risk averse, there are people who are risk taking. So machine may actually give you, okay, for this group, if you are a risk-taking behavior based on your psychological profiling, this is what you should do. Based on your psychological profiling, this is what you should do. So these are things which will happen in the future. So right now, I think it's too premature to put any of this into real practice.
Just one more point to add to that. I think one follow-up question that will come up to in your mind is that then why this XGBoost is giving 60% and why that one? So the thing is, these are all mathematical models, and with the data that we are giving, it might capture some of the features or some of the nature of the function or the features that or patterns that it is representing. For example, some models will capture the non-linearity in the data, some will be working really good in linear data. So that is why some models will give different accuracies with respect to, or a performance metric with respect to some other ones. So we once we understand the algorithm or the machine learning classifier that we are using, we can decide which one to rely on to and which one not to rely on. And accordingly, we will choose the models as well. While like this is from a machine learning researcher's point of view.
So just summarizing in 2 words, it is the property of data as well as the algorithm which defines the best performance of a given model. It is not that XGBoost work well for everything or random forest work. The data as well as the algorithm is important. For a image, a deep learning algorithm works much better than XGBoost.
And just one last question, like for small data sets which we routinely use in our daily practice. Now, do you think that for small data sets, logistic regression may work fine?
Yes. Yes.
Because
perfectly
the models are overfitting.
Answer is correct. Yeah. Yeah. Thank you very much, because we are running short of time. Thank you so much for everyone for being here. I would like to thank my co-panelists.
I request.
And let's take a photograph before we leave. Yeah.
I request
thank you very much.
Chairpersons, speakers, moderators to please, and all those who are there down there on the as the audience, please join us for a group photograph. Thanks to our distinguished speakers for sharing their expertise and insights on AI. We are delighted and we are grateful to our chairpersons for their expertise and thoughtful guidance throughout the session. For further sessions, let's meet in Hall 1.